My name is Nicole Borman. Today is July 20th. The best explanation for the presentation of gout in this 47-year-old man is decreased urinary excretion of uric acid. This is most likely due to a dysfunction in ABCG2, which is a high-capacity urate exporter. This dysfunction would cause a loss of or reduction in ABCG2-mediated renal urate secretion with an increase in renal urate reabsorption. This is the most common underlying mechanism in the majority of gout patients. An increase of urate reabsorption causes hyperuricemia or increased plasma urate. The presentation of gout would not be due to decreased salvage of purines. If there was a reduced purine salvage specifically caused by a deficiency of hypoxanthine guanine phosphoribosyltransferase, such as in Lesch-Nyhan syndrome. This deficiency presents with a large overproduction and overexcretion of uric acid. This does not agree with the patient's test results. While the plasma urate value is consistent with an overproduction of uric acid, the value of the excreted uric acid does not coincide with an overexcretion. If this were the case, the urinary uric acid value would be well over 500 milligrams per day. An overproduction of purines would present with hyperuricemia as well as uricosuriia, or high urinary uric acid. This is due to an overactivity and abnormality of PRPP synthetase. The disease associated with this abnormality makes this enzyme insensitive to allosteric regulation by purine nucleotides. In both of the latter disorders, they are sex-linked diseases and usually present with early onset of gout. Lesch-Nyhan syndrome presents in the first decade of life, typically in boys, and a PRPP abnormality would be linked to an infantile onset form. This also causes cognitive and neurodevelopmental impairments. Since our patient is middle-aged and just developing symptoms associated with gout, it is very improbable that his gout was caused by an overproduction of purines or a decreased salvage of purines. When the patient switched from diet soda to regular soda, his body took in a drastic amount of fructose or high fructose corn syrup in a short amount of time. This change automatically increased his chance of developing gout. Fructose consumption is linked to accelerate de novo purine synthesis as well as inducing uric acid production by increasing the degradation of ATP to AMP. According to Rowe et al., serum uric acid levels rise within minutes of fructose infusion. Plasma glutamine levels would be the best diagnostic to distinguish between a urea cycle disorder and a disorder in beta oxidation. Glutamine is important in the urea cycle because of its role to carry ammonia to and from the kidney and other tissues. In the kidney, glutaminase hydrolyzes the ammonia, regenerating glutamate and a free ammonium ion, which is excreted in the urine. When blood ammonia levels increase, as shown by the patient's blood work, blood glutamine levels will also be increased. Glutamine levels would not be affected in a beta oxidation disorder. In beta oxidation, carnitine is responsible for regulating serum ammonia. A deficiency in carnitine would present with hyperammonemia. The enzyme ornithine transcarbamylase would be deficient and most likely the cause for elevated uric acid levels. This deficiency would lead to an abundance in carbamoyl phosphate, which is alternatively metabolized to uric acid by pyrimidine synthesis instead of proceeding through the urea cycle. Carbamoyl phosphate 1 is least likely to be impaired, as it is still sufficient in producing carbamoyl phosphate.